This podcast is brought to you by the good people at Living with Hemophilia, the online hemophilia community brought to you by Bayer. Living with Hemophilia is the destination of choice for a plethora of useful info, like medical and non-medical tips, helpful advice, information on programs for all ages and stages, leadership opportunities and initiatives, sewing patterns, and videos, the best videos. And because it's on the internet, it's easy to find. Simply type in livingwithhemophilia.com into your search bar, and there you are. Thank you, Internet. Join Bayer's community of fellow hemophilia patients, caregivers, and advocates as they put the live in Living with Hemophilia. You can even like them on Facebook. That's even better because then you can use emojis on their Facebook page and receive all the latest updates. So check out Living with Hemophilia. And before you wish happy birthday to some friend from the 3rd grade or share a funny meme about cats and Mondays, head over to Facebook and like Bayer's Living with Hemophilia page. You'll be glad you did.
There are many different healthcare providers that make up the comprehensive care model at hemophilia treatment centers around the United States and much of the developed world. Physicians, nurses, social workers, physical therapists, and many other healthcare professionals are all crucial team members in this model and can help individuals throughout their lifetime. Today, for Ask the Expert, we will be focusing on the role of physical therapists in the care of individuals with bleeding disorders, how that has evolved in the decades since prophylactic treatment has become more common, and what some of the new research shows in the bleeding disorders community. Welcome to episode 14, our physical therapy episode of the podcast with special guest Sharon Funk. Sharon Funk has been a physical therapist at the University of Colorado Hemophilia and Thrombosis Center for the past 41 years, and I have been really fortunate to be one of her patients over that time period. She has helped me recover from some pretty devastating bleeds throughout my childhood and young adulthood, and even helped me manage injuries long distance when she communicated with my athletic trainers and nurses while I was out of state for college. Not only was Sharon an amazing physical therapist for her patients, she also has spent a good portion of her 30-plus year career participating in research to better understand how physical therapy can help those with bleeding disorders. So thank you, Sharon, for joining us today on Ask the Expert.
Thank you very much.
Is there anything you would like to include that I missed in your background?
No, I think you did a very good job of presenting my background. I would also like to give credit to our HTC here in Denver because we've always had a very, very strong team that worked together to try to give the best care in a timely fashion so that anyone affected with hemophilia could continue to be active in what they were wanting to do.
While I was at the treatment center, you guys kind of helped us really pursue whatever passions we had, which was really cool. So I guess my first question is, when I have my annual visits at the HTC, I see the physical therapist, so usually you or Laura, and I notice that you take, dozens of measurements with some interesting tools. What are those measurements and how do you use those to help you treating your patients?
So when you come into comp clinic at our treatment center, you generally are seen for close to an hour by the physical therapist. That isn't always the case in other treatment centers. So we feel very fortunate that we have that amount of time that we can spend with each of our patients because to really get a full assessment of how you're doing, it can take easily 45 minutes to an hour for the full evaluation. And what we're looking at, what we've always looked at was what was happening to the joints. We want to make sure that the joints aren't deteriorating over time because of bleeding. And sometimes it might be unrecognized bleeding in some cases. So we go over you literally with a fine-tooth comb. And in my early years in hemophilia, that oftentimes just consisted of doing range of motion of the joints to make sure that you were not losing any motion. But over time, as we started looking more closely at joints, we realized that range of motion clearly wasn't the only thing we should be looking at. And it wasn't always the earliest sign of what might be going on in the joint. So we began to look closely at several different items. I guess we started looking closely at more of a set of items in the early 90s. We were looking at trying to quantify if the joint was changing over time, and we did that by looking in a systematic way at several different items that are relevant to joints, what they do, and how they change if there is joint disease due to hemophilia. So we look at swelling. We look at how long the swelling might have been there. Usually that's a question and answer with the patient or perhaps a review of their chart. We look at whether we're seeing signs of any muscle wasting or atrophy, because if a joint is bothering someone, they may not use it as much, and you can begin to see changes from the good side to the side that's having the problem, where the muscle bulk just does not look quite as strong and bulky. And then we begin to move the joint and see what we can feel. Are we feeling some creaking and popping in the joint? And if so, how bad is it? And then we look at range of motion. We use that combined with everything else. And then we also look at strength to see whether there is sort of a backing off of the muscles because possibly they're having pain in the adjacent joints. We look at actual pain itself. We want a subjective report of pain from the patient himself, but also we're looking, as we're doing all these other tests, we're looking to see whether the patient is showing any signs that something might be painful. Like if he has to push on it too much, it might begin to hurt him. And then lastly, we look at gait, and we look at it in a very big global way. We don't look at it with a high-tech gait lab, although we have access to that if we need it. We just want to see how the person is moving through space in their world. Do they walk with any kind of a noticeable limp? Do they go up and down stairs easily? And if they can do both of those things, we ask them to run and we ask them to hop on one foot because these are more difficult skills and certainly might cause more trouble if you have a joint that's having issues. So those are the things we look at closely. We have a few tools we use in our daily activities. One of them is a goniometer, which I like to show the kids is just a giant protractor with arms, and what it's designed to do is to measure angles. So most of the kids, by the time they're in 4th or 5th grade, have learned about a protractor, and so they actually kind of get into realizing, oh, yeah, I had that in my math class, and that's what they're using on me here. So we measure the angulation of the joint as it changes over time as well. As far as other tools that we have to do, I think our biggest tools are our eyes and our hands, what we feel, what we see, and our experience with both people without bleeding disorders and what gait and motion look like, and then a familiarity over time with what patterns of motion you begin to see when the joints are having difficulty.
It's a lot of experience that you've developed over years that you can kind of notice those small differences.
Correct. Yes. And, initially when I started, the treatment centers were just really beginning their very first years of being treatment centers. And, we had our standard physical therapy tools of this is how you measure a joint and this is how you do a manual muscle test. Those are actually standardized processes that physical therapists are taught when they go to PT school. But what we weren't familiar with was when did we begin to see the signs of change in a joint, and should we be looking at things besides just the range of motion? And so that's where the experience came in. And it actually helped when we developed tools that were standardized so that we systematically looked at the joints the same way every time. In our center, we always do what's called a Hemophilia Joint Health Score. Not all centers do that, but it's helped us process how we need to look at things.
Okay, so not every treatment center has the same measurement tools, but is that the one that we use at our treatment center, is that the most common one? Is that what most people use at treatment centers?
Right. As far as the scoring system, you mean? Are you?
Yeah.
Yes. So the Hemophilia Joint Health Score was developed by an international team of people from 5 different countries, the United States, Canada, Sweden, the Netherlands, and there's now been input from India and Belgium. That was an interesting combination of people that came from countries that had more joint disease and other people that came from countries that had access to good care at very young ages for their children. And so it's been a 20-year process to come up with that tool. And it is a good systematic way to take a look at the joint. And it's now being used clinically in more and more centers. The problem with it is it takes a while to do it. So if a treatment center only allots their physiotherapist 15 minutes to see the patient, you're going to have a hard time doing a full HJHS in 15 minutes. However, for research studies, it is now the only valid tool that's out there. And so people are using it for treatment research studies that are investigator-oriented versus also pharmaceutical companies as well.
And so with all these measurements, it seems like it's a pretty comprehensive tool that you're gathering. If you do start noticing changes in those measurements, like what does that indicate for you as a provider, and what should we be thinking about as patients when those things just start changing?
Right. So that's the beauty of this, is that as we have a way to sort of quantify what we're seeing now, it isn't just my opinion saying, oh, yes, it's still a little swollen this year. We actually can give it a number and track it over time. And so when we begin to see those numbers going up, we have to ask ourselves, why? What's going on here? Which of the categories has shown changed? Was it the swelling has persisted for now a year? Was it he was losing range of motion? Was it that he's having more trouble walking? It depends on where the problem is, or it might be in several areas. But then we look at why would this be happening? Most of our young patients now are encouraged to be on prophylaxis, which is the regular infusion of clotting factor preventively so that hopefully no bleeding ever starts in the first place. If by some chance a person isn't on prophylaxis, that might be the first thing that we would look at is that, wow, you're having a lot of on-demand bleeding. This is not really good. We need to talk about a prophylaxis regimen. That's one way we can inform and back up our decision on why we're recommending prophylaxis for someone. But let's say they're already on prophylaxis and now we're starting to see more breakthrough bleeding. Well, then that begs a discussion from the whole team, like what do we think is going on? If it's a really young child, is the family having a hard time getting the infusions in? What's the venous access? Do they have a portacath? Are they trying to do it peripherally and it's just too much? They're maybe missing more than we realized. That's sometimes a problem. Has the child grown? Has his dose increased? And the family hasn't alerted us that they're having the bleeding and that he's grown quite a bit in the last few months. So sometimes that's the problem. It may entail having us look at their half-life. Every person is a unique individual, and though we say that generally the half-life of factor 8 is 12 hours, maybe a particular person consumes it all in 6 hours. So then you would have to change possibly the frequency or the dosing of the clotting factor, or look at a longer-acting clotting factor, or as our current environment is, there are all kinds of new products coming on the market. And, we can look at standard factor 8 or 9 therapy, longer-acting, or some of the other more high-tech products that are currently out there.
You bring up an interesting point with kind of the new products that are on the market, the extended half-lives, the non-factor replacement therapy, and even products, to treat von Willebrand's disease. Has that impacted your work at all? Have you noticed any differences with extended half-life products and joints, or any trends at all with those new products?
As far as a scientific trend, no, because we haven't looked at it yet. It certainly has impacted how we as therapists and actually how the whole team has to think about what's going on with the patient. It's not as cut and dried as it used to be, So we have the same issues when you're having breakthrough bleeding. The question is always why. But then you really have to look at the product that they're on and why is this not working, and is it the product that's the problem? Is it the dosing that's the problem? Is it the fact that they're missing a few doses here and there? Is it the activity level of the child? And I think we're going to talk about that here in a little bit also. But it's actually requiring more discussion on everybody's part to try to figure out what's going on here. And the same would be true if you were actively following someone, say, postoperatively, for therapy, or if someone like yourself maybe had a bleed while they were, playing their sport. How do we get them back playing their sport? What we need to look at the whole thing, basically. It's not just take your factor 8 and call me in the morning kind of thing. So
definitely, yeah, looking at the patient as a whole is super important. I think that's one of the beauties of having comprehensive care clinics too, is that you kind of get to know those patients as individuals instead of just, in and out. So you brought up an interesting point too, just about when we do have bleeds, which I have had many. What's the best protocol for interacting with your PTs, post bleed? And is there a role in recovery that you guys are a part of? And can this have a positive impact on preventing further bleeding in that area?
Yes, those are several good questions kind of all put together. We've always been very lucky here in that we have very good access from patient to therapist. We are in the clinic all the time. We don't live in rehab medicine the rest of the week and then come over here just for clinic days. We're actually here every day that the clinic is open. And that is a huge advantage to our patients, because they get to know us at the same time that they're getting to know the nurses or the social worker. If they're quite young and they're coming in with a bleed, they're seen by everybody all at the same time. Because of that, we're watching them very, very closely, and we're initially perhaps just working on stabilizing the bleed because we don't want them to do too much if the child is still bleeding. But once they're stable, we want to make sure that right away they get back to what they had before. And I'll use an example of ankle bleeding. In young children, we now know and recognize, and it's in the literature, that bleeding seems to start more in the ankles. If you look at some of the really old literature, you will not see that. It will say that the bleeding started in the knees. But what we think has happened is the ankles probably did start first. It's a little bit of an unstable joint as compared to the knee, but when the knee would start shortly thereafter, this was in the days before good clotting factor was available, the knee was so much more of a problem with actual function and movement around in your world. Going upstairs was a huge problem if you had a knee bleed. You could have an ankle bleed and still kind of get by a little bit in moving around, but once the knee started up, it really made it hard to do a lot of things. So then people would focus on the knee and they sort of forgot about the ankles, I think. The ankles were always there. We just didn't pay attention to them. So what they would do with an ankle bleed, and the children would be very creative about this, they just stopped moving it because it hurt to move. And maybe they stayed off of it for a couple days. But then once they got up, they could move around pretty effectively by just turning their foot out to the side. You don't really have to bend and straighten your ankle up and down, side to side. If you just lock it in a 90-degree position and turn it out to the side, you can move around quite rapidly in your world, but with an abnormal pattern. And so then if that persists for a while, that pretty soon that's your pattern. You just continue to walk with your foot out to the side. You may not really need to by that time, but it's become a habit. So we're breaking up those habits, the therapists are, right away. Once the joint is healed. We're going to keep them off of it longer. But then if we notice they're doing well, but they're still turning their foot out to the side all the time, we're going to get right on that so that it doesn't go on for years and become just a bad habit that then created an abnormal walking pattern that ultimately may cause more bleeding in the future.
Right. So the one bleed, if not rehabbed properly, can lead to other issues in different parts of the body?
Yeah, correct. And you might have some weakness, that started if you were out of commission for a couple weeks or something. And then now we're going to turn you loose to your wild and crazy childhood life. That could potentially cause problems too. So we're going to try to help coach you back into a normal, better range of motion, get some strength back, and then return you to your activity level as safely as possible.
I really love that you have so much experience in our community over several decades. So you've seen quite the transition. So as a physical therapist, what are the biggest differences in patient care since you started working at the HTC?
So when I started, there were already patients that had grown up before I ever met them that had significant joint disease at a very, very young age. Children of 5 and 6 years had already developed bad joints. My first patients came with joint disease. I didn't have the benefit of seeing a newborn baby very much, and they already started getting joint disease at a young age. That has completely changed. With our aggressive prophylaxis protocols, we expect them, hopefully, to grow up with very, very minimal bleeding. So our young toddlers, do they have bleeds? Yes, they still can, but we're just right on them. We've increased the treatment also. We were very limited in how much concentrate we gave initially. It was a much lower dosage that was given, and you usually got treated with maybe just one dose because it was still much better than what you had before, which was nothing, or maybe some cryoprecipitate or fresh frozen plasma. So now you had concentrates, and they just didn't give you a whole lot. You got the one dose, you were told to lie low and don't run around on it, and you would slowly get better, but you oftentimes rebled because one dose just wasn't probably enough. Well, we definitely know it wasn't enough now. But back then, the one dose was more than what you'd had before, so it was still better than nothing at all. We've since learned that the one dose at a lower dosage rate of 40% correction was not anywhere near enough. We treat acute bleeding much more aggressively. At our center, we give you a very high dose when it happens, and you get a dose the next day, and skip a day, and you get a third dose. Pretty much every joint bleed gets a 3-day regimen of some sort. If you have a shorter half-life, you might get more than somebody that has a regular half-life. If it's a muscle bleed, we might give it even more aggressively because even though people think, joints are the things we're worried about, which is the truth, we're also finding that muscles can really be hard to treat if they're not treated correctly, and they easily rebleed. So we use very aggressive approaches with muscle bleeding as well in order to keep them healing, because muscles by nature are designed to contract and break open very easily. So yes, we treat so much more aggressively. And then, frankly, if you're on prophylaxis, that's a completely different approach than what I would have had when I first started the job. We only prophylaxed people for brief periods around a very, very bad bleed or a surgical intervention of some sort.
This podcast is brought to you by the good people at Living with Hemophilia, the online community brought to you by Bayer. Living with Hemophilia is the destination of choice for a plethora of useful info like medical and non-medical tips, helpful advice, information on programs for all ages and stages, leadership opportunities and initiatives, sewing patterns, and videos. The best videos. And because it's on the internet, it's easy to find. Simply type livingwithhemophilia.com into your search bar and there you are. Thank you, Internet. Join Bayer's community of fellow hemophilia patients, caregivers, and advocates as they put the live in living with hemophilia. You can even like them on Facebook, and that's even better because then you can use emojis on their Facebook page and receive all the latest updates. So, check out Living with Hemophilia. And before you wish happy birthday to that friend from 3rd grade or share a funny meme about cats and Mondays, head over to Facebook and like Bayer's Living with Hemophilia page. You'll be glad you did.
What are some of the biggest challenges that you see currently in our community as far as like injuries or limitations? Because we have kind of transitioned from everyone having target joints to being relatively healthy now. You know, it's kind of a new dynamic. What are those new challenges that you're seeing as a physical therapist?
What's amazing is how much things have changed even in just 4 or 5 years. And I think that has come with all the new products on the market. Each one has a slightly different mechanism of action. But throughout it all, we've raised a generation of kids who are now, they had the benefit of prophylaxis in the early 90s, and they're now 20 years old. And so they gradually, each generation has become more and more active. As we've gotten better products, better approaches to care, the children just started doing what everybody else on the block was doing. In the past, they might not have been able to keep up, or they would have to miss games because they were bleeding, and then they maybe self-selected out of a sport and went into doing something else because they realized the sport was just too much for them. So that's where I see a huge change, is that pretty much everyone is able to be more active than they ever could have been before. So we still try to give guidelines on the sports that you want to potentially self-select into. The question always was, how high do we need to keep their factor level in order for them to participate in some of these sports? For years, our approach had been to always trough above 1%, because if you could keep them above 1%, then they would theoretically be in the moderate range rather than the severe range. And people thought that that's what you really needed because moderates weren't going to bleed as much as severe patients did. Well, that was fine as long as the patient didn't really do too much. But we all know that mild patients still have bleeds and still get injured and have bad bleeding after an injury. And so over time, as these severe patients began to do more and more and more, they, although their level may have been troughing in the low moderate range, they still were having bleeding. And so the center here began looking at what can we do. Maybe some people are okay troughing at 1%, but maybe a lot of them aren't going to be okay. And the question then became, so what level do we need to trough them at? And even just 4 or 5 years ago at some of the big meetings, the physicians were discussing this. How high of a trough do you really need to have in order to allow the child to play the sport? And that was the great unknown, and they're still working that out. But we are finding it's probably much higher than anyone ever realized.
Right. Very interesting.
Even in some mild patients. So we have some mild patients who've gone on to play their sport in college, and they have been okay at the high school level. And it not in every sport, like certain sports definitely are going to be much more demanding on your musculoskeletal system. We have a young man right now who didn't really bleed much as a mild patient throughout high school. He never really bled. But the minute he got the college scholarship and had to kind of up the ante on the training, he did start having some issues. And so, that tells us a lot. Some of those patients, in order to compete at the level that he hoped to continue to compete at and the level on which his college scholarship was based, he began to have more bleeding as a mild patient. Everybody's individual. A factor 8 patient will have a different bleeding phenotype than a factor 9. And so you can't just say this is what's perfect for everyone, because everyone uses the factor slightly differently. And we're finding through the My Life, Our Future program that the mutations are so much more varied than what anyone ever really initially thought they might be. There are hundreds of variations on a factor 8 mutation.
Right. So that's really highlighting the importance of, having individual treatment plans and really communicating with your treatment center to kind of make that plan that's perfect for you personally.
And having an attachment and a connection to a treatment center, I think, is critical because things are just changing so rapidly that it's important to know what's out there.
Absolutely. I had a question that just popped into my brain. It's related to something that I've heard about microbleeds, and I don't know if it's an actual thing. I've just heard it in the community as, like maybe some microscopic bleeding going on in joints, even when you're on prophylactic treatment. Have you noticed anything about that or heard anything about that?
Yes, it's not just a recent topic. That's been actually discussed for quite a few years. I first heard it when we started analyzing the data from our joint outcome study, which was the sort of landmark study that really showed that a child that was put on prophylaxis at a young age did much better by age 6 than a child that was just on demand therapy only. And that's where the discussion first mentioned this possibility of, quote, microbleeding. It was because the joint outcome study had the two cohorts. One was young children put on prophylaxis. The other cohort was a group of age-matched young children who were just treated on demand. And they had MRIs of their 6 hemophilia-related joints, which are the knees, elbows, and ankles, when they entered the study at about a year to year and a half of age. And they also had MRIs when they exited the study at age 6. And even in the prophylaxis group, it was noted that there were some subtle signs of joint change. And then it was hypothesized that maybe there can be this little microbleeding that, we didn't know was even there. That was the first discussion. So that was, that's been easily more than 15 years ago when that idea was first proposed. I think we're hearing more about it today because it was proposed and discussed in the academic community of hemophilia way back then. But that was before everybody was so routinely on prophylaxis. Now, the majority of the people are hopefully being offered prophylaxis in their treatment centers, and yet they're still having some problems. And so, they've heard, whether they read that article that was published where we mentioned that, and it was in the New England Journal, and then they've focused on that, or it's just word of mouth. Well, there's this thing called microbleeding. I think there's a combination of everything. You can call it what you want to call it. I think it boils down to the same theme that we see with the trough levels, is that we are now beginning to recognize in order to keep somebody playing a sport, you got to keep a higher than 1% trough level. And so if our old prophylaxis was always bringing everyone down to 1%, then they could be having a little bit of subtle breakthrough bleeding that possibly gets stopped because, let's say you're a factor VIII patient, you need your dosing every 48 hours. By the time you get that dose at 48 hours, you might have tweaked something 6 hours earlier, right before you went to bed, and overnight there might have been a slow start to the bleed, but, you still had a tiny bit of factor that was trying to work. And then you got your prophy dose the very next morning, and maybe you didn't even notice there was a problem. But maybe there had been a little bit of a problem. So this is my feeling, that I think it boils down to the trough level and then what happens in those last few hours before you get the next dose. So is that true microbleeding? Because micro to me means little tiny bleeds, I guess. Or is it just a bleed that never got very far because we stopped it right away? So we get, in essence, another really tiny bleed. So I think that, I guess they would have to figure out a way to actually measure that closely. But I think it's all related to the trough levels. Someone without a bleeding disorder has a consistent level all the time. It may not be 100%, it may be 89%, but they're always at 89%. Because normal can be anywhere from 50 to 150%. So someone with a bleeding disorder, they're drifting down. From the minute you get the factor, it's drifting down. You have your peak and then your trough, your peak and your trough. Some of the newer products maintain a higher level of the threshold where you don't ever drop too far below maybe 8% or something. So every product's different. It works differently in every patient. So you can't just generalize that just because this works for you, something else might not work for somebody else. So that's my feeling. I think it's all related to levels and what you're doing and how quickly you get that next dose.
What does the role of physical activity and flexibility kind of play in healthy bodies and joints for people with bleeding disorders? I've never actually been able to touch my toes, so I'm really not flexible. So is that something I should be concerned about and working on?
So We do know in the general population how important it is to stay active, and activity is just critical in a growing child for lots of reasons. They need the exercise for, just good musculoskeletal development. You get good muscles, you get good core control. You are doing cardio as a child that, most people wouldn't call cardio, but you get out on your bike and you ride it around the neighborhood. That's cardio. You didn't go to the club to do it, but you're just moving all the time. And that's what young children do. They don't sit down. So activity is important, and in today's world, we don't seem to be comfortable just turning our children out the front door in the morning and say, see you at dinner time, because it's kind of a tricky world these days. So the activities tend to be organized, and, they may be team sports, they may be individual sports, they may be just a family that chooses to go on a bike ride every Saturday morning or go on a hike, like you have your Backpacks and Bleeders group, and you have set days when you guys gather and go for a hike or a snowshoe or something. And it's just critical. They are now realizing there are some basic science studies that are showing that bone density in people with bleeding disorders, and they were specifically looking at factor 8 mice, knockout mice, that there are some issues with the bone in these knockout mice, and they're looking very closely at that maybe factor 8 is more than just stopping bleeding, but it's also promoting better bone health. So the other thing that we know that promotes better bone health is activity, jumping, pounding, running, which someone with a bleeding disorder wasn't able to do before we had good clotting factors because they would bleed. It's critical that the children today, whether you have a bleeding disorder or not, you need to be active, because good bone health is critical for avoiding fractures down the road. And it may not be till you're 60 years old where you're going to have to worry about that if your bone health has been good. But if your bone health hasn't been good, you're going to start having fractures many, many years earlier than that. And if we know, and they're still working on these basic science studies, they are thinking that the bone health may not be as good in someone who's factor 8 deficient, then we've got to make sure that we're giving it the best chance through other ways, and that would be exercise. We're going to try to stimulate healthier bones through some exercise. But without clotting factor, you could potentially start bleeding. So it's very important. Ultimately, other side benefits of exercise, as we all know, are good. Cardio is good for cardiac health. It also helps with weight control. There is a huge problem with obesity in the United States and Canada, and even now in parts of Europe, it's starting to get worse. We know that exercise can help with that because you're not just sitting around eating all day long, and you're actually burning off what you need to burn off. So it has been shown that people who exercise have lower risks of things like diabetes as well. That's a huge problem that we're seeing more and more of in our country. I would say the guidelines for hemophilia kids shouldn't be any different than the guidelines for people without a bleeding disorder.
It sounds like, we have the same compounding chronic issues if we don't exercise as the general population. So, yeah, I think that's pretty good advice. So I had a question from Facebook. They were interested in doing some 5Ks and half marathons with a bleeding disorder. As a PT, how could you help somebody that's trying to begin to get active and start exercising? What would you recommend for them, or what would you prefer as a PT to see from somebody with a bleeding disorder?
Number one, I think you need to look at the person to start with and see what kind of general hemophilia health they currently have. Is this a teenager? Is this a 40-year-old gentleman? Is it a 5-year-old whose mom runs 5Ks and he wants to run one with her? You have to look at the whole picture and see what's going on. And then you want to look at the joints that would be involved in running. So it's pretty much your hips, your knees, your ankles. And if you clearly have a really bad joint somewhere, I think you need to think twice about how much running and pounding you want to put on that particular joint. That being said, if your knees, hips, and ankles are in great shape and you don't bleed very often, maybe you are on prophylaxis, which we're hoping everybody will be, and I think it's a reasonable thing to do. You shouldn't be going for marathons at really young ages. I think that in our hemophilia population, you would want to work with your healthcare provider and say, look, I'm hoping to run this little 5K that they're having on Thanksgiving Day or whatever it is, and that you allow plenty of time to train, that you have a good prophylactic regimen that you're already on, so that you're hoping that the running that you start to do doesn't cause a problem. Because if it does, you know what happens, Chris. When you have a bleed, you have to stop everything you're doing for several weeks sometimes. And then, then you try to rush back into something and you try to do too much, and then you're at risk of bleeding again. So it's better to start slowly and build up to that and go, don't try to run a marathon first. I would start with 5K and see how you do with that. Now, the long-term issues with distance running is it's really hard on your body. And I've had a couple patients who have severe hemophilia who have run marathons. I don't know if their joints in 10 years are going to get more arthritic faster than if they had never run. But, the person that I'm specifically thinking of, I think always trained. He started slowly and trained in the best way he could. He worked very closely with a local physical therapist in his hometown so that any aches or pains he was being seen for immediately to make sure something wasn't starting. And he really tried to listen to his body. So he has been able to do a few marathons. I have a daughter who runs marathons. She has all kinds of leg and feet issues going on all the time. She does not have a bleeding disorder. I also have a milder patient who does a lot of running. And when he trains at a high level, like running 100 miles a week for training, he begins to have problems. Now, does he have more problems than his teammates who run the same distances but don't have a bleeding disorder? We think he does. We don't know 100% for sure, but we think he does. So, do you start prophylaxis on a mild patient in order to do that? That's the question. And it's not just a question of what that individual wants, but it's a question for society, like, really, is this something that we should be doing, prophylaxing someone so they can train at 100 miles a week? When you're looking at the economics of healthcare and people are looking at that more and more and more, is that appropriate? And I'm just throwing that out as a that's not necessarily my belief that we shouldn't let them do it, but there are people out there that would say they don't need to be running marathons because look at how much factor they have to take. Yeah.
So to just kind of wrap up, I have two more questions for you. What are PTs looking at as far as research in the bleeding disorder community currently?
So right now there aren't a lot of basic science studies going on. There are some PTs that have been looking at some very high-tech gait lab information and what it does to joints in hemophilia. There have been some research projects looking at development of the young child, whether it's somewhat delayed in children with hemophilia versus toddler without a bleeding disorder. That has been looked at. There have been some things in regard where we've used, for example, the HJHS as one of the outcome measures for looking at quality of life and how things changed when maybe adults have gone on prophylaxis, because in some places they're still not advocating that adults continue to prophylax, for example. They think that once we get you fully grown and you're good and you're not running around like a crazy teenager anymore, that maybe you don't need prophy anymore. So they're looking they use the HJHS as one of the outcome measures for that kind of a study. Those kinds of studies are going on. And actually, there are probably a lot more that I don't even know about yet, but the World Federation meeting is in a month in Scotland, and I imagine some of those ideas will be displayed on poster sessions and oral presentations.
Our final question is, are we missing something as patients that could help physical therapists do their job better? And how could we, patients, help you do your job better? Like, what information could we be giving you guys? Could we be communicating more with our physical therapists? What would be the ideal for you guys as physical therapists as far as communication?
I think you can provide a lot of information that you don't even know you're capable of providing. Like I said, we're fortunate here because we, quote, live in the treatment center. So we are with you when you're injured or when you've got a goal to work towards something. We help you get better or work toward that goal. If you only have the PTCU once a year, you're not going to have that opportunity. As prophylaxis has become more mainstream with everyone, and subsequently the kids are doing more, they're picking a sport and they're trying to stay with it, they're trying to get good at it, then you as the patient could say, I really love my swim team, or I really love playing tennis, but I want to make sure that I don't get hurt and have a bleed that's going to keep me from doing this down the road, and ask for that kind of input. And maybe you have a treatment center where you don't have that easy access to the PT. Maybe you could start asking for that kind of help. And, you might have to do it slightly differently than the way we do it here because we're here all the time. You might have to make an appointment at a different time with your therapist, over in the main PT clinic. But I would say ask for that help, ask for that guidance, because we'd much rather you get started safely and be prepared than get injured and then be disillusioned and say, well, maybe I can't do this because I always get hurt, and maybe with just a little guidance. I'll use your example of your flexibility, for example. Pretty much most adolescent males are really tight. That's kind of a common thing in men. It's not unusual. So what happens when you do have decreased flexibility? You're at risk of muscle strain or tear, even in someone without a bleeding disorder. So that's otherwise known as a muscle bleed. That's the other thing. Sometimes our terminology throws patients off. They'll say, well, no, I don't have a bleed. I just pulled my hamstring. Well, let's discuss this. A strain is a tear. Tears bleed. You have a bleeding disorder. And depending on how aggressively you treat that or how bad the tear was, you get better or you maybe don't get better without a lot of factor. So just, for example, getting on a good stretching program, it's hard for all of us to be consistent with our stretching program, but oftentimes if we do have a goal motivating us, like I want to be able to do the hurdles in track and not strain my hamstring, you're going to have to do those stretches, those kinds of things that aren't unique to a bleeding disorder person. So, yeah, the same things that other people need to do well, we need to do well too, but we just need the factor coverage to do it well. And a discussion with your physicians about your trough levels, depending on what sport or activity you're trying to be really good about doing.
Thank you so much, Sharon, for joining us today on Ask the Expert. It was really fun chatting with you and letting you share all of your vast experience with our community. So thank you so much for being on the show today.
Thank you, Chris. It was a pleasure.
Have you checked out Living with Hemophilia yet? If you have, kudos to you. Not only are you eager to join this exciting community of discourse and helpful information, you're also a keen listener and patron of the arts. But if you haven't taken a swim through livingwithhemophilia.com, take a moment to pull it up on the old internet. I think you're going to love it. Helpful content, relevant updates, and most of all, a bunch of people going through the same things you are. It's a growing part of the online Living with Hemophilia community brought together by the good people at Bayer. Also, put it on your Facebook to-do list. Hit the like button on Living with Hemophilia's Facebook page. It's a good alternative to looking at the slideshow of your neighbor's recent foot surgery. I mean, unless you're into that sort of thing. Living with Hemophilia from Bayer. Check it out.
I hope you all enjoyed this month's episode of Ask the Expert, all about physical therapy. Physical therapists play an incredibly important role in helping those living with bleeding disorders stay healthy, and I hope the wonderful insight and experience Sharon shared with us helps you all connect with your physical therapist at your center at your next visit. As we highlighted in this podcast, everyone's bleeding disorder and body are unique, so please remember to always consult with your healthcare team before trying any new workouts or physical activities. They will have the most up-to-date information and can help you make the best decision for you. I would also love to say thank you to our sponsor, Living with Hemophilia, the online hemophilia community brought to you by Bayer. Living with Hemophilia is the destination of choice for tons of useful information, like medical and non-medical tips, helpful advice, information on programs for all ages and stages, amazing global leadership initiatives, sewing patterns, and videos. Please visit their website, livingwithhemophilia.com, and like their similarly named Facebook page. And that is all for episode 14 of the Ask the Expert podcast. We'll be back next month with another expert interview. BloodstreamMedia.com is your one-stop shop for all of Bloodstream Media's podcasts for the bleeding disorders community. Once on BloodstreamMedia.com, don't forget to follow the links to subscribe to the Bloodstream podcast, the Ask the Expert podcast, the Powering Through podcast, and the Bloodline podcast on iTunes, Stitcher, Spotify, or wherever you listen to podcasts. Have an idea for a future episode of Ask the Expert? Have a question that you would like to hear an expert answer to? Email us at mailbag@bloodstreammedia.com. You also find Bloodstream Media on facebook.com/bloodstreammedia and on Twitter @bloodstreaminfo. This episode of Ask the Expert was written by Chris Bombardier, produced by Patrick James Lynch, Rob Bradford, Joshua Sterling Bragg, Avra Friedman, and Colby Crow. Artwork by Ryan Geelan and Katie Wright Mead, and the Ask the Expert pod is edited by Allison Stoney. I'm your host, Chris Bombardier, and until next time, keep on climbing.